Okay, so I want to do benign lesions today because you guys see a lot, so you need to be familiar. So when the breast become developed in utero, the butt actually starts coming from the groin area and travels up towards the axillary line. Okay, so excuse me, along this line, if there's any interruption, people could get more than one nipple besides the breast tissue. And sometimes it looks just like a pigmented nevus, but slightly different. So when you see that, just know that you get what they call an accessory nipple. Anywhere along this line, it could happen on the abdomen or the chest. Now that's what it looks like. You see, it's got a little brown areola and the nipple. Sometimes you don't see a lot of areola, you just see the nipple itself. And sometimes you see more than that. This here is the same thing, but it looks a little scarred up. But always think that if you have a line going down here towards the groin with anything that looks like this or like the other thing, you're talking about accessory nipple. Okay? Okay, everybody's kind of knows what seborrheic keratosis look like. They're rough, kind of corrugated, sometimes scaly plaques. Okay, they're benign. Okay, sorry about that. Then dermatosis papulosa nigra. You all know that. And when we remove them, it's cosmetic. And usually what we do is I inject each area there, and then I cauterize it very lightly, and then I take a gauze and rub against that and take this stuff out. And you can do it for many of these. And it's a cosmetic charge that we would do, and I'll quote whatever you want to. Tell the patient that they're going to get a hypopigmented area, and then over time, the hypopigmentation will darken up more towards the skin color, but that takes a few weeks, sometimes a little longer. So they're nothing more than a benign cosmetic type of growth, very much like the seb care, but usually occurs in people of color. Oh, we forgot to invite Kim. Laura, she's gone. Okay, next time. So that's dermatosis papulosa nigra. Cosmetic skin tags. You don't know what they look like. They're part of the benign lesions. You could see them anywhere in the body, associated with weight gain and age. Weight gain and age. And, again, they're cosmetic in removing it unless it's irritated. And if it's irritated and you note that on your chart, then you can go ahead and remove it and bill the insurances for it. Sebaceous hyperplasia are usually small little papules on the cheek or the forehead. Most of the time they're right here. Some of them are slightly yellow in color, like this one. So just note that the only way of removing that is if you shave that and cauterize it, you need to tell the patient that it will come back. So if patients sometimes come in and say, listen, my daughter's getting married. Can you get rid of it? And if it's a sebaceous hyperplasia, tell them unless you actually do an excision and stitch them up, the root of this will come back. So if you could shave it and kind of like cauterize it very gently, sometimes not even cauterize it, and it'll heal up pretty good if you shave it flat with the skin. But you need to warn them so that they don't get ticked off and say to you, I paid you for this and it's come back. So explain to them that to really remove them, you have to excise them, otherwise they will come back. Lentigos are flat macules or patches with the melanocytes only in the epidermis. Okay, solar lentigos are basically most of them do not have any excess melanocytes, but they produce a lot of nonin, as a direct stimulation by ultraviolet light. Usually occurs in the hand. The best way to do that, but you can see it in the face, is to use laser. Now, we don't have lasers. I saw my lasers, and I've not bought any. And in New Jersey, not so in Pennsylvania or other states, mid-levels cannot use lasers, so I've not invested in any of this because I do not want to be a slave to my machines. So lentigo simplex are basically something you're going to see with mostly with patients who are elderly or older and in sun-exposed areas. I'm not going to get into syndromes. Okay, you need to read to find the syndromes. Right now, I want you to acquaint yourself with benign lesions. I want you to hear about it, try to memorize it, and then you could do some reading on your own. Syringomas are little tiny papules. They're small. I actually have one on my face. And again, like sebaceous hyperplasias, you could maybe rough them up and shave them, but they will come back unless you punch excise them out. So you could do a lot of tiny little punches, put a few stitches in them, and you can put a stitch in each area you punch out, and they will not come back. If you shave them, for cosmetic results, just tell the patients they will come back because the root has not been removed. Xanthelasmas are fatty deposition mostly around the eyelids, okay? And they will recur no matter what you do. We used to put an acid on it, bichloroacetic acid, and it's kind of tricky to do, but I don't expect you guys to do it. But if patients come in, they may or may not be associated with a high lipid profile. So, if nothing else, ask them if have you had any blood tests checking your triglycerides and cholesterol and LDL and VLDL. If they say no, I would recommend getting a lipid profile as a fasting blood test to make sure that they don't have raised lipids, because if they do and they're not being treated, you could save their lives in the long run. Otherwise, don't treat these. Refer them to a plastic surgeon if you need to. Okay, these are xanthelasmas right here. It's not a great picture of that. These are more prominent. Same thing here. So just know they're called xanthelasma, and just look for a lipid profile as far as removing them, refer them out. Same thing here. You can see that here, and here, and here. Okay. Now there are different forms of xanthelasmas, xanthomas. They could occur on the tendons. They could just occur as eruptive xanthomas like these. The eruptive xanthomas are associated with a very high lipid count, and I'm talking about lipids in the hundreds. So when you see a patient like that, you're gonna have to get a lipid profile because you're gonna save their lives. They're either gonna come down with a severe necrotic pancreatitis or a severe, heart attack or stroke. So when you see these are eruptive xanthomas. This is a tendinous xanthoma. We have some more pictures of that. You can see what they look like. They're papules, slightly yellowish. And in kids, you might see and we'll deal with that in another session. They're called a xanthogranuloma. Xanthogranuloma. They occur anywhere in the body, including the nose, the face, or the trunk. So just keep that in mind for later sessions. Exactly, another eruptive xanthoma. And when you see them, it's really life-saving for you to make sure that they get their lipids checked right away, and treated extremely quickly, so they don't have a major, health problem because they're at a big risk. So they're called xanthomas. So they're yellow papules, wherever, and sometimes they appear, like I said, on the tendons. They tend to be bigger. They don't come up quickly. And eruptive xanthomas, you could get them within, a couple of weeks, few weeks. These take much longer to appear in patients, and I don't believe they're associated with any harm, like the big lip accounts that I know, but nevertheless, just check it just to make sure. Knuckle pads are these pads on the knuckles. Okay, there's not much you could do for them. Okay, um, they can grow rapidly. Up to 4 centimeters within 4 months. Okay, it's just a thickening area on the skin of the knuckles, and they may be primary or secondary. Okay, primary usually inherited, familial, and of course sporadic. The secondary ones are due to, you know, some sort of irritation to that area. Be it from whatever. Okay, and there's really not much you can do about it. If it's due to habit, ask the patients to stop, intimidating their own skin over the knuckles. Pyogenic granulomas. Patients will come in complaining of this lesion that looks like that's very friable, and it bleeds on the slightest touch. And I'm talking about like a ton of blood comes out of this. It's a collection of blood vessels underneath the skin, and the only way you can really cure this is by excision, because when you kind of curette it and desiccate it with electric cautery, it's a very temporary relief. Most of those will come back. So when you see these, if you can excise them, and excise them into the subcutaneous. And if you're not capable of that, just refer them out. I do these all the time. Patients are referred to me by people in the practice. They're called pyogenic granuloma. A lot of times they're due to some sort of trauma in the area. Somebody's picking on their skin, wherever, and some irritation causes them to occur. And sometimes they just occur spontaneously. Um, this
I
is
have a
one.
question.
What's that?
For the pyogenic granulomas, are we billing them cosmetically since they're normal and benign, or are we
No, no,
doing
that's
that?
not. No, whenever something's being built cosmetically, I will announce that in these discussions. These are not
Okay.
cosmetic. It's a problem. It's a medical problem. Patients lose blood, and it's a condition that needs to be treated, as soon as possible because they tend to grow. Now, in this
Okay.
patient, maybe this guy was picking the cuticle and developed a pyogenic granuloma. Sometimes they occur spontaneously, and sometimes they're they're part of the side effects of patients who take isotretinoin, also known as Accutane. There's some other trade names. So this is a pyogenic granuloma. Now, to remove this, okay, I got to do a deep shave excision, and once I do that, because the nail matrix comes out in here over the underneath the proximal nail fold, the nail will never be the same. And so I always tell patients, I haven't signed consent, that your nail would probably not come back, and if it comes back, it's going to be distorted. But they can't walk around with a friable papule that's going to continue bleeding. Now, angiomas. What's that? Is there a question? Okay. Spider angiomas. Can you guys hear me well?
Yes.
Okay. So angiomas come in all sorts of shapes. There's cherry angiomas, spider ones that look like little spiders with tentacles. Okay, they're benign. Sometimes a lot of it are seen with connective tissue diseases, especially in scleroderma. Okay, in areas where patients have sclerotic areas. Um, these, I mean, you could try to cauterize it, but you would probably scar the tissue, and you'll probably never get all of it. So these lend themselves pretty well to treatment using lasers. I used to do those all the time too. So these are called spider hemangiomas. They're thought to be secondary to some form of increased estrogen on board. Spider hemangiomas. Okay, this is a spider hemangioma, but you can't see the tentacles because it's so There's so many of them, they kind of blend into each other. Phosphorodices, okay? The Sometimes the apocrine glands um, increase. Actually, the sebaceous glands that increase in numbers. Okay, to where they're aberrant. They actually form in the on the lips. You know, underneath the armpits, inside the mouth. Okay, and I'm not sure where this is. Um, but one of the things that there's nothing you could do about them. And two, once in a while, they've been described to itch after having sex. Okay, specifically after having sex, and you could see these. So if you see this cobblestone type of appearance with a slight yellowish in color, they're form sebaceous hyperplasia involving the mucosa of the lips. You can see one here. You can see they're scattered throughout here, as they are here. There's not much you could do for it, you know. I mean, you'd have to remove the entire mucosal area, which is with an advanced flap. You don't want to do that. So I would just assure them that it's not cancerous, nothing to worry about, just there, and hopefully they don't complain of itching after sex, you know. Now, venous lakes look like this. They're nothing more than little small veins with a bleb that comes out of the mucosal areas. If you touch them, you can take a glass slide, you know, and if you press down on them, you'll find out that they disappear when you press down on it. I'm sure you guys might worry about, is this a malignant melanoma? So if you're not sure when you're starting out, okay, take a glass slide and push down on it, and it will disappear. Sometimes they look more purple, sometimes they look more black. They're very common. You can remove them, it's cosmetic. You could just simply numb it and cauterize it, explain to the patient that they will have a small scar as a result, but it'll stop growing because they could get, you know, large. And when you cauterize them, they eventually fall off. Instead of being black, you might have a slightly white scar. There's one here, and so on. They're usually small, but they could get to be larger. You see, it's a little purple. So it's a purple papule. Blue nevi we talked about. You have to make sure that it's not a melanoma. They're rare. They rarely form a melanoma unless there's a couple. There's a common blue nevus and a cellular blue nevus. If anything's going to happen, it's going to happen with these cellular ones. And you know, you could excise them, not to take any chances, and sometimes you'll actually get on your path form a note from the pathologist asking you to go ahead and excise them, you know, just to make sure they're not part of a larger lesion that you're missing. So you can see how big they get, and sometimes these blue pigmentations have um, forms that are patchy rather than papular-like. And you know, we talked about that, the nevus of Ito on the shoulder, the back of the shoulder, the nevus of Ota, which is on the face. But we'll see it in other chapters as we go over. But all these are forms of blue nevi. If they're cellular blue nevus, more than likely the recommendation will be that to excise them because they might show some atypia. If the common blue nevus, they're usually left alone and observed. They're usually seen more in Asians than Caucasians. Now, angiokeratoma, if you break this down, angio means blood vessels and keratoma means keratin or skin or epidermis. Okay, these look like more typically like this. They're like purple, small purple papules, Okay, most of the time they're found on the scrotum. Um, when we remove them, it's also cosmetic. We numb them and then cauterize them. But once in a while, you'll find someone comes in and tells you that it's staining their underwear or pants because they tend to bleed because they're in angio, meaning they're vessels, but they have skin on top of them. So that's why they're known as angiokeratoma or Fordyce. Fordyce, it's just like sebaceous hyperplasia or Fordyce's disease, itch. These are different. These are just growths that, with a component of blood vessel. These are some examples of what they look like. And you can see most of them are in the genitalia. Angiokeratomas, just remember that. Now, there are some congenital ones, and they're found in different places, like the angiokeratoma of Mibelli. They all have something in common that they're purple, but one thing you need to understand is that when you see purple papules on the feet or legs, you also have to rule out Kaposi sarcoma because that Kaposi sarcoma, okay, whether it's on the usually appear in older Italian, Mediterranean by hereditary um, on their legs, and they tend to be malignant and they can metastasize. They're not really quick in metastasizing, so that's the differential.
Good night, guys.
If you see that, you need to do a biopsy to make sure you're not dealing in a punch biopsy to rule out um, what I just told you. There is another form of something that looks a little purple, okay, and it's called an angiosarcoma, and they're very deadly, very, very deadly. I just had a patient with one of those a month or two ago, and on the scalp, and the treatment for that is extremely aggressive. These patients usually go through major surgeries where their entire scalp is removed, and then they get radiation on both sides of their face. Okay, so Kaposi sarcoma versus angiokeratomas of Mibelli on the feet and legs versus angiosarcoma on the scalp. And they could get to where they become circumscribed, meaning that they're like they're whirly, you see, and extensive. So the name changed to angiokeratoma. And sometimes you also have to um, exclude malignant melanoma. Okay. Okay. Well, who's in the car? Is it mine? Okay. These you could see this could be a malignant melanoma. So you need to do a punch. Will it be a little bloody? It might be. If you're scared or nervous, send it to someone who's more knowledgeable and has a little more experience than you do. Okay, pilomatricoma. I believe a couple you saw me remove from a young girl. She had it on her forearm not long ago in one of these offices. I did an excision. And what it is, it's something that occurs usually in young people, but people up to into their 40s can get it. It's a benign tumor that looks a little bit blue, like this, and when you feel it, it's kind of a little bit hard, and it has calcium in it. And when you cut it out, it looks like not only a waxy tumor, but a hard, a hard kind of calcific tumor. And when you actually go into it, you could actually see calcium deposits. But it's benign. It's known as pilomatrixoma. They could also become malignant, but it's rare. It's not often that happens. They could occur anywhere in the body. These are some examples. One here, here. This is an unusual side. This is an unusual side, but it can happen anywhere. Pilomatrixoma. Now, they can turn malignant. It's not common that they do that, But since they grow anyways, we take them out and we get them tested. Pilomatrixoma. Um, Dermatofibromas tend to buckle in. They're thought to be secondary to scar formation in areas of trauma, most commonly seen on the lower extremities. They come in all sorts of shapes. They could get to be very, very large. Usually they're small. So if you pinch the lesion between your index and your thumb, you'll see it kind of go into the skin. It's called a dimpling sign. Okay, and this is what they look like when they're small. They could get large and nodular like that. They have all sorts of forms. If you're not sure, you could just do a biopsy if it's too big for you to remove and excise. This is what they look like. You can see most of them are on the lower extremities. Sometimes you see them on the upper extremities, especially the arm. You see, this is what they're trying to feel. When you do that, the center of it kind of dips in. So it's called a dimpling sign. But most of these are on the extremities. You can see it. Sometimes you have to actually either do a biopsy or remove it because sometimes it's like when they turn color, you can't tell if you're dealing with something benign or malignant. So you see, this could be a melanoma for all you know, so can this. So there's no reason to keep them there, especially if they get large and they are of this color. These are examples of that. Ganglion cysts are cysts that evaginate from the synovium of a joint. So the synovium puckers up and it lifts the skin up. We usually don't take care of them. We send them to an orthopod because the problem is in the joint. However, once in a while, we see what they call digital mucus cyst. And with a digital mucus cyst, you get the same thing, but it's not as, it appears more like a papule. It usually appears on the fingers. It's much smaller. So sometimes it could cause a scar to occur by shaving them deep and then cauterizing the base. And the scar is formed here at the root of the sinus going up. You may be able to make them go away.
Sure.
What's that? Okay, so the ganglion cysts occur mostly from the wrist up. The digital mucus cyst occurs more typically at the joints of the hands between the first and second phalanges. Keloids. Other than injecting it with cortisone, where they are bothersome, and or topical steroids, I would recommend that you do not do anything about cutting them because you could make them grow larger than what they are. We won't even talk about the treatment of them. It's complex. So I would just do whatever it takes to try to alleviate the discomfort or the itching by either intralesional injections of steroids or topical steroids. They're very common around the ears from ear puncturing. Sometimes they develop from just a form of acne on the chest. I've seen plenty of that. So the job there is to keep patients from breaking out and developing keloids. So it's important to put them on systemic antibiotics and try to prevent any form of inflammation. The darker the patient is, the more apt they are to develop the keloid, and some of them just develop it from acne, trauma, surgery. Piercing is a form of trauma. Okay, you're not going to see much of this because that looks like you can think that this is a digital mucus cyst, but it's not. It's called a giant cell tumor of the tendon. Sometimes if a patient has a history of gout, these are gouty tophi that could occur at the tip of the joint, okay, commonly, but they can occur elsewhere, by the elbows, etc. You can see there are deposits of uric crystals here. You won't see much of that either these days. Rheumatoid nodules with a patient with a history of rheumatoid arthritis, this is what they look like. You might think that they're tendinous xanthomas, but they're not. So sometimes you have to differentiate that, and sometimes you'll do a biopsy, and it's okay to do a biopsy. And you do a punch, not a shave, because you got to go a little deeper, because the pathology is in the dermis. There's all sorts of reasons why the skin develops calcium. When it does that, it's called calcinosis cutis. The most common ones you're going to see in the practice of dermatology in these areas are calcinosis right on the scrotum. Sometimes they're plain cysts, sometimes they're cysts with calcium, and sometimes they're just calcium deposits. It bothers some guys, and usually what I do is I excise them. I actually cut them out and stitch them up. So just know that they're amenable to surgery. And if there's a real problem with calcinosis cutis, sometimes it's due to different syndrome. So read up on that and get familiar with the syndromes that cause calcium deposits in the skin. These are some other examples. Scrotal calcinosis. Pilonidal cysts usually occur at the crack of the butt. If you guys see any cysts here, refer them to a surgeon. You can call me, take a picture, send me a picture. If you usually have sinuses, and usually you have to create a huge hole here and let it fill in with granulation tissue. So they cause a scar between the sinus that comes from the spinal cord area and the skin itself. Pilonidal cysts are almost always in this area, at the crack, and sometimes a little bit below that. Patients will tell you they've had it for years, and this is what they look like. If they're inflamed, you can put them on antibiotics. Sometimes that helps. Dermoid cysts are not common. They're a vestigial remnant of a number of things. They're usually found on the face. Many times they may be attached to the brain. So you have to be careful about referring patients that you think might have a cyst. If they've told you that they've had it for many years, maybe since childhood, then you really need to work them up, send them for an x-ray of the skull and or a CAT scan. But I won't do surgery on that until they're worked up to make sure they're not dermoid cysts. Now, these are very common, okay? And you'll see the little cysts like that, especially around the eyelids. And if you look at the pathology, this is a gland. If you look at these areas right above the gland, that's what they call decapitation excretion, where the cell produces a discharge and discharges into the lumen. This then gets filled up and it looks like a little bubble on the skin. They're either due to the apocrine glands or the eccrine glands. They're really easy to treat. You numb the patient, you take an 11 blade, okay, pinch this, get all this fluid out of there, take a little cautery and cauterize the base of it. And 9 out of 10 times they don't come back. This is what they look like. They're always around the eyes. They could be single, they could be multiple. And they're also, whether they're apocrine or eccrine, you're not going to be able to tell the difference, and it's not important. The idea is to just pinch them, get the fluid out, and cauterize the base. This is a condition where hair comes out of the nose. they're kind of in there, and there's sometimes a few hairs coming out of the one of the follicles. You're not going to see much of that either. This is also rare, steatocytoma multiplex. What happens in this is a development of a bunch of cysts, okay? There's cysts underneath the skin. Commonly, they're multiple, they're small. They occur, you can see here in the mid-chest, the forehead, the neck. There's not much you could do about it because you could cut them out, but there are really lots and lots of these. So if you do a biopsy, they have a very interesting look under a microscope, and we could come out to that conclusion. So if someone has many of these, go ahead and take one out if you can, or do a biopsy of that, and rule out steatocytoma multiplex. See the bunch here, and a bunch on the neck, and that's what it's about. I'm not going to get into the pathology of that. You can see many cysts. Usually they're like grouped. We're not going to skip that. Fox Fordyce. Remember, I told you when there's a lot of now in the armpits. Okay, you remember the ones on the lips? They're called the Fordyce's disease. They're sebaceous glands, sebum glands. Here they tend to be apocrine glands. The apocrine glands are found in the armpits and the groin, underneath the breasts, and sometimes in other areas of the body, but these are where they are concentrated. Okay, and I need to retract. It's in this condition that they tend to itch after sex. The other condition doesn't do that. They're just benign. They're underneath the mucosa. I wish they'd just change the Fordyce's name because it's confusing to talk about it. Because if you haven't talked about it in a while, which I've not, sometimes you need to keep in mind the difference between the apocrine concentration in these areas and the sweat glands in the mucosal areas that do not itch. So if you get patients that have these in the armpits, they don't really bother them much unless they have sex, and some they do. There's not much you could do unless you do an extensive surgery to remove them. There's no pills or creams. And if they itch, you could try some topical steroids to see if it helps. But other than surgery, you can't do much about it. Now, there are a lot of other benign lesions on the face. Remember, we saw syringomas, angiomas on the face, sebaceous hyperplasia, that kind of stuff before. The trichoepitheliomas, okay, they're usually something that people end up getting as a genetic predisposition. They're dominant traits, and they have to be differentiated from other adnexal tumors like basal cell carcinomas because they look like they could look like that if there's only a couple here and there. Sometimes there's many, sometimes there are a couple. The ones that have many of them are the ones that are inherited as an autosomal dominant trait, and the ones that have like scattered and few in between are usually acquired, and they have to be. And sometimes it's hard to tell on a biopsy the difference between what they call a desmoplastic trichoepithelioma, which I don't want to confuse you with and tell you what that's all about, and a basal cell. So sometimes we actually do a Mohs and or an excision on trichoepitheliomas because we're not absolutely sure they're not basal cell carcinomas. But this is what they look like. See if they're isolated like this or like this. This is much easier to see, but sometimes you just get one lesion on the nose, and you do a path on it, and it comes back as a desmoplastic trichoepithelioma, cannot exclude a basal cell carcinoma. We then take it out. Okay, sometimes you get other benign tumors on the face and or the lips called trichotillomoma. They also originate from the hair follicles, just like the tricho means from the root of the hair or the hair follicle. So you got trichoepitheliomas and tricholemomas. For these, they're more superficial, and we usually don't do anything other than shave them off for cosmetic reasons. And angiofibromas, as it implies, it's a blood vessel with fibrous tissue. And you could see them, they look like pigmented nevi. They could look like serogomas. They could look like distinct trichoepitheliomas. They're going to, now there are different syndromes like and neurofibromatosis. One of the ways to diagnose it is showing by seeing fibromas, fibromas around the nails. They occur in other places. This has a name called fibrokeratoma because not only does it project out like a fibroma, but it's also surrounded by thick skin. This is a very typical. It has a little ring around the base. You see that? That's pretty typical. And it's got a fibroma that kind of juts out. So usually what we do is we numb it and we shave it around here, submit it to pathology, and usually we'll get that diagnosis as a fibrokeratoma. Okay? But sometimes it's known as an acral fibrokeratoma because it's on the acral area, meaning the fingers or toes. Acrally means the most distant in location on the body. See, this is a pathology of a fibrokeratoma. You see, this is a real thick area of keratin, and this is the collagen. Okay, and so it's a fibrous keratin projectile lesion. That's why it's known. And there's a lot of blood vessels in it too. So a fibrokeratoma or an angiofibrokeratoma or an acral fibrokeratoma or something of that nature. So keep that in mind. Okay. This is something that is very common. It's found in many males, and it's benign. Nothing to worry about. You will see males come in asking you. They start getting paranoid about that part of the body that they love so much, and they say, "Hey, what are these things? Do I have syphilis? Do I have these tumors that are growing?" And they're always on the corona of the glans penis. So they're known as pearly because they are pearly. They're kind of whitish, right? Penile on the penis. Papules because they're tiny little papules. And you can see they surround the corona of the glans penis. Here and here. And there's nothing you have to do. It's a normal variation on a man's penis. Same thing here and over here. They could get right to the shaft, but they usually don't extend beyond the area where the corona meets the shaft of the penis. Pearly penile papules. Neurofibromas are soft in nature if you touch them. They tend to like protrude a little bit in, and they're soft. Many patients that we see with multiple neurofibromas have Recklinghausen's disease or neurofibromatosis, and they could get big, so we tend to remove them on request when they start bothering the patients. See, they could occur in all sorts of ways. You'd be surprised when you see a patient with neurofibromatosis, um, how extensive they could be. Now, this is you may not be able to know the difference unless you kind of think of this. Lymphangioma circumscriptum. These are lymphatics that grow out of the skin. And in order to remove them, because they look like this, they have to be excised. And there's a small chance that even after excision, they could come back. But they're worth trying to excise it because they tend to grow. They're lymphatics that grow underneath the skin. And sometimes they get pretty big. Okay, we're going to skip that. Nevus sebaceous is something you will see, not commonly, but pretty common. And you got to really pay attention. These are plaques that are verrucous, slightly yellow in many patients, but not. It doesn't have to be. And it's something that grows after a child and starts, maturing a little bit when they're 2, 3, 4 years old. And they're usually typically found on the scalp, but can be found on the face and neck, but typically on the scalp. And I like removing it because one is they tend to form benign and malignant tumors inside. The most malignant tumors are like a basal cell carcinoma, and then there's a whole host of other type of tumors. If I throw names at you, it wouldn't be fair. So if you see a plaque that's slightly yellow like this, refer them to either me or somebody that with my approval could excise them. I can excise pretty large ones. This is what typically they look like on the scalp. They're a rough yellow plaque. Sometimes they're a little brown, but they can occur anywhere on the head and face. And you're not sure what it is, just do a biopsy. Remember, biopsies are important to help you differentiate what they have. They're known as nevus sebaceous, and many of us will say nevus sebaceous of Yadison because that's kind of the language we use. He was the one who described it, and so we give him the respect of saying that. This is, you're never going to remember this name too well unless you say to yourself over and over while you're sleeping. It's known as a syringo cyst adenoma papilliferum. Okay? And we tend to remove those too because they get big, as you can see there. Okay? I don't remember what they form. I don't think they form much of anything. Very rarely they could turn malignant, so that's, I guess, one of the reasons you might want to do that. They usually don't, but they can turn malignant. This is what they look like. They're on the scalp. Syringo cyst adenoma papilliferum. And they have different forms. You can see that. Now, one of the things that you really need to learn is the painful tumors of the skin. Because when you see patients that come in and you talk to them and they say to you, "Oh yeah, you know what? It hurts. These things hurt me. They're painful when you touch them." Okay, so those tumors you want to remove. Why would you want to hang around with something that hurts you? So this is a list of the painful tumors of the skin. Now, frankly, the most common ones that you're going to see, dermatofibromas are not really painful, okay? So they're really not painful. I've never met someone who told me that, this hurts them. So I do, so they're not painful. The most commonly painful are leiomyomas, this one, okay? Eccrine spiradenoma, and they all look alike. except for a glomus tumor. These usually tend to occur. They tend to occur by the nail, around the nail bed, or any part of the nail. Okay, I mean not. I'm so sorry, not the granular cell tumor. Forgive me. I meant the glomus tumor. This occurs around the nail or the nail edges. Okay, acrospiradenoma, leiomyoma, and neurilemoma. If you can remember that, you'll impress somebody with an angiolipoma. These five tend to be sensitive, slightly painful, and so when you see these patients, you may want to consider helping them get over the pain by removing them. Okay, so now let's see what they look like a little bit. This is a syndrome of people being born with a bunch of these. It's known as blue rubber bleb nevus syndrome. You'll hardly see it. It's not very common. Neuromas are a lot like neurofibromas. And I don't have a picture, but they look like neurofibromas. Leiomyomas can occur anywhere on the body, and they just look like you see, like these papulonodules. If you're not sure what they are, just do a biopsy and you get the diagnosis. Leiomyomas can form cancers. They're called leiomyosarcomas. This is leiomyomas. Eccrine spheratinomas, and they can also occur anywhere, but the extremities are more common. And they look like this. You see, a lot of this stuff are not going to be that distinct. So you got to, take a numb it and take a scalpel to it, shave it, and see what you're dealing with. Because sometimes you're going to find things like Merkel cell carcinomas, and they're very, very highly malignant. They don't look like anything. They're small when they first start out. But by doing that, you will save somebody's life. Then they're just as aggressive as melanomas, if not more. Eccrine spheratinomas occur usually on the, actually anywhere as well. The glomus tumors usually occur only on the distal areas. Usually they can occur elsewhere, but and you see this purple area right there. Purple area right there, you got to cut the nail out and then get rid of this whole tumor here. The nail will not grow in well after that. There's another if you touch it and press it down, the patient will say to you, ouch, that hurts. They're usually blue in nature. This one ate right through the nail. Angiolipomas. So there's a number of painful lesions on the tongue, and you tend to see tumors. If somebody sticks out their tongue and says, I got a growth there, okay, what are you going to do? Are you going to run for the hills, or are you going to feel comfortable in doing a little shave? What you can do is just take the tongue, grab it with a gauze, move the tongue around a little bit like I do, and then patients don't feel the pain of injection. Inject an area here and do it like a little deep shave, put some mouth cells on, and this is how you're going to find out if you got a squamous cell carcinoma or a benign granular cell tumor. But granular cell tumors occur mostly in the mouth, on the tongue, on the inner mucosa of the cheek, or the lips. Now, sometimes you'll get calcium deposits throughout the skin, calcinosis cutis, typically, you saw that on the scrotum. Then you get something called osteomas that contain, this is calcium that you're looking at. They contain calcium and that occur as solitary lesions or multiple lesions elsewhere in the face, the trunk, anywhere in the body. So that finishes the benign tumors of the skin. And let me see if I could grab part of another small lecture. And we'll start that. Let's check this out. Let's see what we have here. Feet, nail, and oral disorders, okay? Okay, pitykeratolysis. You may see a few of these during the year. And what it is, the patient will show you the feet. And this is basically what it looks like. You see little tiny little pits in the feet, the plantar area of the foot. And if you have a Woods light, sometimes it'll show up more. And it's caused by a few bacteria like these. Corynebacterium, actinomycosis, myces, micrococcus, and dermatophilus. So that if you treat that with either systemic or topical tetracycline, they usually go away and you become a hero to your patient. I only want to show you something that you might see. The other day, Brian was in the room. I tried to explain to him what keratolysis exfoliativa means. What it is, people will come in and they'll show you their hands like this or their feet and say to you that their hands and feet are peeling. No, they're not itching at all. They just peel. So once a year, sometimes twice a year, in some people, it's not very common because most commonly we see a form of eczema, will develop peeling features of the palms and soles of their feet. Okay, and it looks just like this, just a peeling. If you put them on Lachydrin, excuse me, or Amlac over the counter, they'll take it away in a 2-3 days, a week or so, and so on. Another benign tumor of the feet is known as an eccrine poroma. You can see it coming. It looks like a fibro tumor. This is a big one. It doesn't matter what you do. You see a growth, you biopsy that. Typically, they look like this. They have a collar around it, collarette, and in the center, there's a nodule that's growing out. Do a biopsy of this, you'll find out the diagnosis, and then we could go in and remove it. Pemphigus, 50% of all patients with this blistering condition have erosions. You see, this is an erosion of the gums. There's erosions here, and then there's some starting out here. So that's one way of diagnosing. Look into the mouth. Epidermolysis bullosa, there's so many different types of it. I'm not even going to talk about that. It's pretty rare. Maybe you'll see one if you're in dermatology for the next 20 or 30 years, maybe you won't. The most common things that I would think about would be something called cicatricial pemphigus. It's like pemphigus vulgaris, but it only affects the mucosa of the lips or the conjunctiva. Erythema multiforme, that condition, which is most commonly due to herpes and or drug reaction, forms target lesions, could also affect the inside of the mouth and the lips. This yellow stuff is just an exudation from the lips because the mucosa is very thin. Many times it's associated with these target lesions on the palms of the hands. So you might have them inside your mouth, palms of the hands, sole of your feet, and if it's really bad, You may even see it on the body. Herpes gingivostomatitis. So if you think you got the first case of herpes that anybody gets, is very often associated with one, malaise, two is severe lymphadenopathy, three is painful lesions. If you want to scrape a little bit of that and put it on a slide, you can see multinucleated giant cells. And if we ever see that in the office, I'll be happy to show it to you. But if you have anything that affects the lips, first time, okay, with small glands, consider that in your differentials. Then you got hand, foot, and mouth disease. Usually you'll see other things going with that, maybe lesions in the feet, the hands. Aphthous stomatitis, APHTHOUS, is just due to stress, and sometimes you just see ulcers only in the mouth due to stress. They come and go, but they're painful. So, one needs to put them on pain relief medication, not Percocet, but things you could put in your mouth, swish it around, and then spit it out, and it'll keep it comfortable for a while. Are you all there still?
Yes.
Okay.
Yeah.
Yes.
Yes.
Okay, good. These are grouped vesicles. Whenever you see grouped vesicles, you're dealing with something in the herpes family. Okay, if it involves a dermatome, it's herpes zoster. If it's just in one area, it's herpes simplex. You could do Xanthus. Perhaps remember what I told you about aphthous stomatitis? Okay, they sometimes look like they could be herpes, but usually patients that have this do not have recurrent episodes. Well, they can have recurrent episodes, but it's usually not associated with lymphadenopathy and basically feeling bad. They usually are just focused on the lips or the gums and after stomatitis. Lupus rarely affects the and forms ulcers. I guess it can, but I really have never seen one of those. Discoid lupus usually affects the skin of the face, the ears, sun exposed areas, and leaves depressed scars. I imagine it could occur in the mouth. I've never seen one of those. But if you have systemic lupus with a positive ANA, I guess you could get anything. Now, lichen planus, when you get that, hopefully you have other signs of it. But if you don't have other signs of lichen planus, such as pearly polygonal papules, some of you guys saw it this week or last week, okay? Sometimes it could be isolated just to the mouth. Sometimes it could be isolated just to the fingernails, whereby it causes a scarring type of situation known as a pterygium. But that's one of the things you have to consider. And it is so bad and so erosive and so painful that most of these people have to be treated with like high doses of systemic steroids, or they tend to lose such amount of weight that they become malnourished. So keep that in mind. I've actually had to treat a couple of people in 30 years. So it's not that common with erosive, diffuse oral lichen planus. Scrotal tongue is a tongue that is sometimes associated with. I actually forget what it is, but you have a geographic tongue where you see plaques, and it moves. It moves from every other day. You'll see new bumps in the tongue, large plaques. A lot of times it's associated with psoriasis. At that ends, is it? Oh no, nails, Bowes lines. Okay, you know what? Let's pick this up Next time I'll try to do the same conference, hopefully next week. And since we recorded this, I might be able to send you copies of what we recorded. You can listen to it. Or I could put it on YouTube and have you listen to the recording. So I'll let you know. Are there any questions that you might want to ask me? Did some of you take notes?
I took lots of notes.
Me too.
Okay, try to go
I
over.
guess my only question will be like for biopsies in the oral pharyngeal area. You mentioned ones like usually the punch biopsy would be the best.
Well, in the oral mucosa, okay, the reason I do punch and I don't go deep is because I like to put a stitch or two in to try to let it heal in quicker, you know.
Mm-hmm.
Um, uh, and that is usually on the inner cheeks, the mucosa on the inner cheeks. When you see lesion on the tongue, you have to rule out. There's a lot of conditions that involve the tongue with tumors, and if you don't feel comfortable doing it, I understand. Um, you could always send them to an oral surgeon to do the biopsy. Um, on the tongue, I usually just scrape it and put some mud cells on the oral mucosa, the inner mucosa. I usually do a punch and I put a 4-0 nylon suture. Just helps the patient to get over it quicker. They come back to see me a week later, I take them out. But each one of you will have a different level of confidence. So, if you feel uncomfortable, always call me, ask me questions. I'll help you through all this stuff, but that's, at least you know.
Okay.
Okay? All right, so with that, I bid you all a fair night, and I'll see some of you tomorrow. I'm sure you're all tired from today's work. I know I am. So thanks for joining me, and we'll go from there, okay?
Have a
Thank
good
you.
night.
Good night.
Thanks a lot. Good
Night.
night. Laura.